Operators, the Hawaii Emergency Management Agency, Healthcare Association of Hawaii, Hawaii Association of Directors of Nursing, Hawaii Medical Directors Association, and Mountain Pacific Quality Health. We usually have a brief presentation, then open up for time for questions and discussion up to about 3 p.m. And we ask you to use the chat box to submit and queue up the questions. Okay, so next slide. This is a schedule for our upcoming sessions. Just for a quick preview, this coming Wednesday, we'll have COVID readiness in care homes because we have, in addition to nursing homes, Hawaii has a lot of care home operators. And so if you know any care home operators, please invite them to this session. We want everybody to be ready. Okay, and then next Monday, planning a COVID unit. Okay, we will be, next slide, we will be offering CMEs. Nurses can use use the CMEs for CE purposes as well. And we also offer certificates of attendance to all participants who complete an evaluation. If you haven't yet registered, we encourage you to do so after the webinar. And the evaluations can be found on the website under the evaluations tab, or we will actually be putting the link in the chat box as well. And at this time, we ask you to enter your name into the chat box for attendance purposes. And for those of you calling on the phone, I will ask you to unmute yourself and tell us your name so we can write it down. Let me see, so far we actually don't have a lot of people calling in from the phone, so that's good. Okay. Okay, a couple of announcements for today. I just want to point out that there is a new tab on our website that has local and national. Oops. Hello? Hello? Okay, so there is a new tab on the website that has local and national resources from the Hawaii State Center for Nursing. So that's just new and just put there. And also, just to note that we recently updated some PPE resources for Hawaii on the front page of the website as well. So please refer to this and share it widely so that everyone can get enough PPEs. And also a reminder, the next slide is that the folks from the UH Pacific Basin Telehealth Resource Center wants to provide assistance to help your facilities become telehealth ready. They have a weekly webinar, and there's another one coming up this coming Thursday. Okay. Okay, I'm hearing some voices here. Let's see. If you're not speaking, please mute yourself so we don't get all the extraneous noise. If you are on telephone, I'm just going to ask you, point out real quick, can you just say your name and so we can take your name down on the chat? 733-7988. Unmute yourself. Any of the others? All right. You guys are shy. Okay. All right. Maybe later. Okay. So, so today's topic is COVID symptom management. And today, our speakers are Dr. Takeshi Uemura with the Department of Geriatric Medicine, who is boarded in both geriatric medicine and palliative medicine. And with us also is Dr. Did I lose everybody? Is Dr. Eric Chin, calling from Yakima, Washington, who will be sharing his perspectives as well. Hello? Hello? Just please go ahead.
Okay.
I seem to have lost, my whole screen went blank, so go ahead.
Okay. I think I see some echo. You may want Dr. Wan.
Yeah, I
here we go.
Get out.
Oh. Okay, great. Okay. So thank you, Dr. Wen, for the introduction. And hi, everyone. I'm Takeshi Uemura, and I hope everyone had a good weekend now because the all the beach parks are open again, even though I don't think you can sit on the beach, but still, I hope you had a good weekend. But anyway, so as a geriatrician and a palliative care provider, I work for nursing homes and then hospice. And today I'm going to talk about symptom management of COVID-19 in nursing home setting. And because I posted in my Facebook page about this talk, and I heard from some folks from Japan, they want to join this session. So this must be the first geriatric echo session that has audience from Japan. So I'm pretty excited about that. And also, I know there are many non-physician providers as well on this call. So I created this talk to provide educational information for all types of providers. And also, I'm hoping to a great discussion with Eric Chen, who is a friend of mine from my fellowship training in Mount Sinai. He has tons of hands-on experience in dealing with COVID in nursing home, and I'm looking forward to the discussion after my lecture. So everyone, please think about what question you want to ask and then enter them in the chat box. Okay, next. So why is symptom management important for COVID-19 patient? COVID-19 can cause severe symptoms, especially dyspnea, and yet there is no virus-specific treatment. So that means the symptom management can be one of the main treatment for this disease. And also in nursing home settings, some patients' goals of care is only comfort measures, and also they may not want to be transferred to hospital. That means those who work in nursing home need to know how to manage symptoms, especially given that most of the nursing homes do not have the capabilities to consult to a specialized palliative care physician. And then as I will be presenting in a minute, most of patients with COVID-19 will have only mild symptoms. That means you may not be able to refer to hospice if the patient only has mild symptoms, even though the COVID-19 can be a deadly disease after, later in the course. Again, this means you need to know how to manage symptoms without help from hospice agencies. Next. So what kind of symptoms can COVID-19 cause? Three major symptoms are fever, cough, and shortness of breath. And less commonly, COVID-19 can cause chills, sore throat, muscle pain, chest pain, new loss of taste or smell, nausea, and diarrhea. Next. COVID-19 is very different from other typical respiratory infections that we usually see in nursing homes. So in order to provide sufficient symptom management of COVID-19, it is important to understand its clinical course. So I'm going to talk about the clinical course for the next couple of slides. This slide shows you a typical course of COVID-19 patient who's hospitalized and died. In the first week, the patient has fever and cough. Then the patient developed dyspnea. And in a couple of days, they develop ARDS, acute respiratory distress syndrome, that requires mechanical ventilation. And then the patient died within a couple of days, even after the intubation. Next. These are the CAT scan imaging of the lungs of a COVID patient who developed ARDS. ARDS is a widespread inflammatory process in the lungs that leads to the blockage of airspace with fluid, which is shown as whitish material on the CAT scan. This obstruction can cause severe hypoxia and usually can cause death unless there is ventilatory support. ARDS from bacterial pneumonia usually develops over a couple of days. But I heard from many friends and pulmonologists in New York who treat COVID-19 patients, ARDS due to COVID-19 develops much quicker and the most severe, usually within hours. So this is very different from what we usually see in bacterial pneumonia. Next. This slide shows you 4 different types of clinical course of COVID-19 in nursing home patients. This idea of classification was developed by Dr. Jim Wright, who works in a nursing home in Virginia, I think. And then his facility has been hit by a surge of COVID-19. So the first type, according to him, is named as indolent course deadly. The patient in this course have a fever and respiratory symptoms in the first 24 hours, then become stable for 3 to 5 days, and acutely become very ill, and they die within 24 hours after that. Next type is named as acute respiratory failure. And patient in this course develops symptoms of fever and acute respiratory failure and die very rapidly. According to him, they die within only 6 to 12 hours since the onset of the symptoms. The next type is named as sepsis-like picture. In this type, the patient would suddenly develop an automental status with hypoxia and hypotension without fever. I believe this type of patient also typically die, even though he did not provide the time course. And then the last course is named indolent course. And actually, and unfortunately, a majority of patients actually follow the indolent course. In this course, they have mild symptoms, including fever and cough, and maybe shortness of breath, but they recover after 7 to 10 days. Next. I want to quickly mention about asymptomatic patient in nursing home, because I know many of you have heard asymptomatic patient, even though they are positive for COVID-19. In this study, they did a facility-wide prevalence survey for COVID-19 when they found out a couple of patients were positive for COVID-19 in the facility. They did a test on 76 residents, and 48 of them turned out to be positive for COVID-19. And surprisingly, 56% of them were asymptomatic at the time of testing. However, a majority of asymptomatic patients subsequently became symptomatic, usually after 4 days. That means even though we know some patients can be positive for COVID-19 and yet still asymptomatic, they usually develop symptoms after a couple of days. Next. This slide shows you a cohort study of nursing home residents from Kings County, Washington, where COVID-19 hit nursing homes hard. In this nursing home, 101 residents got COVID-19, and 54% of them required hospitalization, and 33% of them died. So even though we know that COVID-19 can be a deadly disease in nursing home residents who have multiple comorbidities and then very frail, still about 65% of them survive COVID-19. That means if a frail nursing home resident get COVID-19, we should not assume that they will certainly die. Actually, many of them will only have mild symptoms. Next. So what these all mean to us. First, I think it's important to recognize that it is very difficult to predict which patient will become very ill and which patient will only have mild symptoms, even though we know chronic condition and age can increase the risk of serious condition. Many of them actually recover from COVID-19. However, significant portion of them also die. And this decline of the condition happens very quickly in a range of hours to a few days. And also the onset of symptom to death is only a week or so. That means, as I mentioned last week in my previous lecture, the importance of advanced care planning, it is crucial to clarify goals of care, especially if they get COVID-19. And then you have to be prepared to manage the rapid development of severe dyspnea. And also family needs to be informed about the possibility of rapid decline so that they won't be surprised. And also I want to point out that figuring out when to refer to hospice might be challenging given the rapid change of the patient condition. Hospice referral is done by terminal chronic conditions. If the patient has only mild symptoms, you won't be able to make hospice referral. But then Still, these patients, may develop acute decline and die within hours. So this is unpredictable. So you may not have chance to refer them to hospice. Next. I want to give you a couple points and then provide symptom management tips in COVID-19 patient. First, I know I'm repeating, but clarification of goals of care is crucial. And this should be done using a value-based approach. That means you ask the patient what's important, what matters most to them, and then use those information as a guidance for the treatment plan. If they say comfort is most important, you have to provide comfort. The more certain you are about the goals, the more comfortable you will be to provide symptom management, which may require aggressive medication titration if the patient develops severe dyspnea. And because the development of dyspnea happens very rapidly, you have to have medications for symptom management in hand, which usually include morphine and benzos. You should not wait until the patient develops severe symptoms. Otherwise, you will not have time to wait for the medication to be delivered, which may take hours. Since COVID-19 caused severe dyspnea, this symptom may not be manageable with only PO medications, since PO meds takes time to kick in and to be titrated. Therefore, you may want to think about how you can escalate symptom management to include IV or sub-Q medications if needed. Also, COVID-19 might be a good timing to review medication. You want to stop all unnecessary medications and reduce the frequency of medication administration, if possible, so that you can reduce the unnecessary exposure of the nurse who need to deliver medication to the patient. Also, the patient may need active monitoring of symptom development. So you may want to think about introducing video monitoring so that the nurse would not need to enter the room frequently, and that saves PPE as well. Since COVID-19 can cause severe stress to family, regular communication with family is crucial. And as always, IDT approach is important to provide comprehensive care to the patient and family. Next. So if you do not have advanced care planning done before a patient gets COVID, you should do it as soon as you find out the patient has COVID. Make sure you know who will be the decision maker if the patient becomes seriously ill, and you need to explore patient's value. That means what matters most to the patient. If the goal is clearly to provide comfort measures, you focus on managing symptoms. Next. Since you need to use opioid to manage symptoms, I want to give you a brief review of the opioids. First, it is very important to know the pharmacodynamics of opioids, meaning how quickly it works and how long it lasts. Typically, patients will have peak effect from PO opioids 30 to 6 minutes later they took opioid. And this effect, I'm talking about the effect of not only for pain, but also for dyspnea. Therefore, if you wait more than 1 hour after patient took a as needed opioid, patient would not get additional effect. That means if patient is symptomatic after 1 hour, you should do something. Do not wait more than 1 hour. IV works quicker, so you should not wait more than 15 minutes before taking additional action to control symptom if you use IV medication. Duration of action for opioids are 3 to 4 hours. However, if patient has renal failure or liver failure, this can be longer, usually to 6 to 8 hours. So if you schedule morphine, you give morphine every 4 hours unless patient has renal impairment. In nursing home resident, actually many of them have renal impairment and typically require dosing every 8 hours or 6 hours. Next. If you need to use opioid, morphine is always the first choice because it is cheap, effective, available in various forms, and also most clinical studies were done using morphine. However, morphine is not recommended for severe renal impairment, which is here defined as creatinine clearance less than 30. You have to notice that I'm not talking about creatinine value. You have to calculate creatinine clearance, since you have to incorporate not only creatinine values, but also age, weight, sex, in order to estimate their renal function. If patient has renal impairment, the safest medications are fentanyl and methadone, and hydromorphine and oxycodone that follows. Next. Okay, now I'm gonna talk about each specific symptom. I will cover dyspnea, cough, excess secretion, acute pain, and delirium. Next. First, dyspnea. So dyspnea is a subjective feeling. So do not rely only on SpO2. You may see a patient who has normal SpO2, but still has significant dyspnea. Dyspnea can be described as breathlessness, inability to take a deep breath, air hunger, or chest tightness. The patient may engage in pursed lip breathing and also may express anxiety, fear, or panic. Next. Since we are talking about the nursing home setting, I want to mention about the challenge of dyspnea assessment on dementia patient. If patient has significant dementia, always ask about their current state only, meaning you ask them if they have symptoms right now. You do not want to ask them about the past, meaning how long have they had this symptom, or since when, or what about last night? If the patient doesn't remember these things, they may provide false information. So just focus on the current state. Then you may want to use different terms to describe dyspnea, like choking, tightness, since they may not understand certain terms. And also give them time to respond. Dementia slows down language processing, and I understand we are all busy, but do not rush them to get an answer. Then you should pay attention to nonverbal clues, including grimacing, frowning, irritability, how quickly they're breathing, and SpO2. If they have dementia, they may not call for you even though they have dyspnea. It is important to proactively check in on the patient. Next. Same for assessing dyspnea on patients who are somnolent or comatose. Severe medical condition can make a patient somnolent, but that does not mean that they do not feel dyspnea. You should assume that they still suffer from dyspnea. Since they cannot speak, you have to pay close attention to their facial expression. If their breathing is labored, respiratory rate, and SpO2. Next. So how do you treat dyspnea? First, you do a non-pharmacological approach, meaning put the patient upright and start O2 if SpO2 is below 90%. Just as a tip, there is no additional benefit of increasing O2 flow above 5 liters if patient is only using nasal cannula. So you don't have to do like a 10 liters on nasal cannula. Also in COVID patient, high flow nasal cannula or BiPAP are not recommended because they can create aerosols and increase the risk of infection spread. If you notice wheezing or rhonchi, the patient may have bronchospasm. In that occasion, an albuterol inhaler may help to expand the bronchi. It is important not to use nebulizer treatment because it can also create aerosols. Nursing home resident may not be able to use the inhaler correctly though, so that can be a challenge. Also, you can consider using steroid if you think the patient has bronchospasm. I know there's some concern of immunosuppression by giving steroid, but there is no conclusive evidence also on whether or not steroids are safe in COVID patient. I mean, if the steroids are bad in COVID patient. And if the goal is comfort, I think it's worth a try to give a steroid. Next. Then if the patient is still dyspneic, you should use opioid. Any kinds of opioid will work for dyspnea. Use PRN first. And after finding the right dose, I recommend to give the dose around the clock, since the patient may not request PRN, and also, therefore, without around-the-clock dosing, dyspnea can be undertreated. For opioid naive patient, 5 to 10 milligrams is the initial dose for PO morphine. Next. So this diagram shows you the flow of dyspnea management. It is included in the pocket card in the distributed material. So you can refer to that later. But basically, so treat the underlying disease first and give O2 and start opioids. If the patient is actively dying or require comfort measures only, here they recommend to use opioid aggressively, since the symptom can be severe. If the patient has severe dyspnea, IV opioids are preferred over PO, since it can work quickly, and also it can be titrated up much quicker. I understand some people feel nervous about using opioid for dyspnea due to the risk of side effects and then toxicity. However, that's why you have to have a clear picture of what the patient's goals are. If the goal is comfort, what's the point of being worried about causing side effects? Your job is to make the patient comfortable. This is called in palliative care world as a double effect. I'm not going to talk about it in detail, but again, do not afraid to use opioid. And then if you feel the symptoms are overwhelming, call a palliative care physician if available. And if not, you can reach out to me by email or something. Next. I will quickly overview medications for cough. Codeine and dextromethorphan both work for cough by suppressing the cough reflex. And also all other opioids like morphine, oxycodone work for cough suppressants. It is unclear if there's an additional benefit of adding codeine if the patient is already on opioids. And as I said, NEPs are not recommended. However, you can try an inhaler of albuterol. Next. Treatment for excess secretion is shown on this slide. You can read it in detail later, but guaifenesin works by actually stimulating the cough reflex and also stimulating the airway secretion so that the patient can cough up mucus. On the other hand, you can use anticholinergics such as scopolamine or glycopyrrolate to dry up the secretion. However, you have to watch for side effects of anticholinergics, including dry mouth, which can be actually very distressing to patient, and also urinary retention. Also, you have to note that scopolamine can cause delirium, especially in nursing home residents. On the other hand, glycol does not pass the blood-brain barrier, and therefore glycol should not cause delirium. Therefore, glycol is usually recommended for the geriatric population. You can use mild, you can use mild suctioning, but never do deep suctioning, since it is undoubtedly uncomfortable. If the patient has increased secretion in imminent death phase, they are called terminal secretions, and we believe it is not bothering the patient anymore. Therefore, it is more important to educate the family that this is not causing suffering, since the family can get anxious by hearing the gurgling sound from the patient's throat. Next. I will quickly go over acute pain management. Pain assessment can be challenging in nursing home patients due to cognitive decline. If patient is severely demented, consider using scales such as PAINET, which I will explain to you in the next slide. Again, do not ask about the past or time course of the pain, just focus on the current state. Then the same as dyspnea, even if the patient is somnolent due to severe medical condition, you should assume that the patient still feels pain. Since the patient won't be able to tell you if they are in pain, you should gauge their pain based on their facial expression, body posture, restlessness. If you suspect pain, you should try pain medication to see if those medications will, if those manifestations will subside. If you suspect acute pain in COVID patient, you can use acetaminophen first. The max dose is 3 grams per day in geriatric population. I usually use 1 gram TID PRN. NSAIDs are not recommended for COVID-19 patients since there is a concern that it can increase the risk of severe condition. Then if the patient still has pain, please use opioids as needed. Next. PAINED is a useful scale for assessing pain in nonverbal patient with dementia. It assesses 5 domains, and the sensitivity is 92% and specificity is 61%. You can read this later to know about the PAINED. Next. Severe dyspnea and other severe condition can easily cause delirium in nursing home resident. First, as always, do a full exam and look for any untreated pain or urinary retention and correct them if you find any. And also, you may want to make sure that the environment is safe, since these confused patients are at high risk for falls. Then do non-pharmacological approach first, which include optimizing environments and medications, and also eliminate any tethers. Pain is the leading cause of delirium. You may want to try to give acetaminophen or a dose of opioid to see if this calms down the patient. Then you can give Haldol and lorazepam. I know lorazepam can worsen delirium in geriatric teaching. That's what we learn in geriatrics, but actually it works for terminal delirium. Next. As you've seen, the medication you will need for symptom management are mainly morphine, Haldol, lorazepam, and Glycol. Since the development of symptom can happen very rapidly, it makes sense to prescribe a comfort kit, which I usually prescribe for hospice patients, even before a hospice referral. Meaning when patient only has mild symptoms, you should consider prescribing these medications. Next. So this slide shows you medication management for other symptoms, so you can refer to this later. Next. I want to touch on communicating with family. Since the family cannot visit the patient, it can cause severe anxiety to family. Also, some may feel guilty and sad without being able to be by their side when their loved ones are sick. Make sure you have a system to provide regularly scheduled calls to family. And it is important to expect emotions from them and you respond to it by using empathetic statement, by using nurse, which is shown on the slide. Since there is a possibility of a rapid decline, you should tell the family what to expect. IDT approach to family is important to provide comprehensive care. And since processing a dead body infected with COVID requires special procedures, you may want to make sure which mortuary can handle this situation. Next. This frame love provide guidance how you can help the family to say goodbye via phone or video. This was developed by VitalTalk. You can read the script later, but the key is to encourage them to say 5 things to their loved ones. Ira Byock, who is one of the most famous palliative care physicians in the United States, wrote a book titled 4 Things That Matter Most, which is shown on this slide. In that book, he says, please forgive me, I forgive you, love you, and thank you are the most important thing to say in the last moment. And then adding goodbye to these 4 things now is known as 5 things to say. So you want to suggest them to say any of these 5 things over the phone or video to their loved ones at the last moment. Next. And then you validate what they want to say and expect emotions and respond to it. Next. Okay, so take home message. Acknowledge the uncertainty of the clinical course of COVID-19 and prepare for a possible rapid decline. Confirm the goals of care and pay attention to what matters most. Use opioids for refractory dyspnea and consider prescribing a comfort kit early on. And communication with family is crucial. Next. These are the useful resources, so you can refer to it later. And next. And thank you. So if you have any questions, feel free to email it to me. Thank you.
Thank you so much. We have a ton of questions, so hang in there. Here we go, right? Oops, where'd I go? Okay, so I'm just gonna scroll all the way back here. Okay, what about the asymptomatic? Oh wait, I'm not exactly sure what the with progressive hypoxia. What about the asymptomatic or I don't know. Dr. Saltzman, did you have a context for that one? That question?
Yes, thank you. This is Dan Saltman. I'm an internist. I thought there were a lot of reports of people having hypoxia as almost the only symptom, that they really weren't symptomatic otherwise. And that could come early, and it could lead to, it could be the prelude to rapid decline because it was not entirely recognized as what the problem was. But there's a lot of talk about the hypoxic effects and how it's not exactly like ARDS. There's a bunch of doctors on the internet saying that it's not, you know, in the ICU, that it doesn't behave like typical ARDS, and that the usual ventilator protocols that they would use for ARDS were not fully effective in the COVID patients. And that as a strategy, some people are suggesting early, and I think this happens in nursing homes a lot, but early serial testing for hypoxia and treating the hypoxia if you see it starting to decline without any other symptoms.
Yeah, thank you for the question. And I think it's important to separate treatment for COVID-19, like a medical treatment, and symptom management. So in palliative care world, we always care about symptoms, meaning not the numbers. So if patient doesn't, I mean, I know, you know, COPD patient and then who has hypoxia, but still saying, oh, I'm okay, I'm okay. In that case, I don't know if you need to give patient opioid. But always pay attention to how the patient is feeling rather than the numbers. I think it's important.
Okay. Okay, Craig Nakasuka, Dr. Nakasuka, I recommend you need to rehearse with the staff a scenario of rapid respiratory decline similar to running a code to ensure no suffocation symptoms at the time of death. I'm going to invite Dr. Eric Chin to comment on that. Did you ever do that?
You know, this is probably a better question for Dr. Wormera because he's the palliative care specialist. I would defer it to him, actually.
Oh, okay.
Sure, yeah. But I think it's a good idea. I mean, I haven't done yet. But again, it sounds scary to have like this rapid decline of respiratory status within hours. So I think we have to have system to respond and then make sure the patient is comfortable. Yeah. So thank you for the question.
Maybe you can put together a script for us or something.
Yeah,
that would be so, nice. Yeah. Okay.
I have one.
Yeah. Would you treat with oxygen if patient was hypoxic but not symptomatic? I think we talked a little bit about that. A little bit. Ever use oral albuterol if dementia patient cannot use inhaler?
Never tried.
I've tried it. No, I mean, you know, not in the context of COVID, but I've done, 2 milligrams and 4 milligrams of oral. I've, not very often, but I've tried. I'm curious if other people have.
Some of my patients, I did just switch them from nebulizers to albuterol, especially in the patients with dementia. No, it's probably not as effective. If you can consider adding a spacer, it probably will work better. Also, a lot of people are end-stage COPD, and you simply just couldn't switch them off, and they are dependent on the nebulizer. In that case, we let them stay on the nebulizers. But the goal is try to avoid the nebulization as much as possible. Definitely.
Okay. All right. Question for Larry. Any benefit for positive asymptomatic or mild patients who use spirometers, personal breathing exercises as prophylactic measure? These exercises.
I don't know if there's any research, but it sounds like it's good. I mean, why not? If patient can remember, I think it's worth. I think breathing technique, and also in dyspnea management, if patient can cognitively process doing like a meditation or deal with the emotional distress is important to treat the dyspnea. So anyway, I think it might be a good idea.
Okay, there's a comment on the use of NSAIDs and if there are studies out there, and I think Dr. Saltman said that World Health Organization, there was no evidence or problems with the use of NSAIDs in the COVID infection. So let's see if there's any. Okay, might not matter as much in hospice palliative care, but for dextromethorphan, there apparently is an article here about caution for use of dextromethorphan, as it acts on sigma-1 receptors, promoted viral infection in laboratory experiments, and researchers said that its use merits caution and warrants further study in the context of COVID-19.
Oh, I didn't know.
Thank you. That's worth looking into. Okay.
Yeah.
Okay, what about the promotion of frequent oral care?
Oh, you mean the wetting the mouth? Yeah, it is very important. And then we see patients who has like a dry mouth and then no one is around. So it might be a good idea to place oral care every shift at least. Yeah, it is very important.
Okay, so we actually don't have further questions. So I'm sure there's more is going to come up, but I'm going to just open up to Dr. Chin. He actually has been experiencing some outbreaks out there, and maybe you could just share with us what you've been seeing.
So in terms of symptom monitoring, right now I've cared for over 100 residents now, living in the nursing home with COVID-19. I definitely see that a third of my patients who were diagnosed really remained minimally symptomatic throughout, and they had no symptoms at all. And 3 weeks into caring for these patients, I started wondering myself, when are the symptoms going to peak? And actually, what we're doing is that once we have one confirmed case in the building, the Yakima Health District then would advise us to screen the entire building and test every resident and staff. And after one confirmed case, in about 3 or 4 days later, when the screening results comes back, then you will actually find out the prevalence rate is about 20% of our patient. So in a building of 100 residents, as soon as we have one confirmed, then you can expect about 20 residents will come back positive. And now, looking back, some of these residents, they really have no symptoms and they remain that way. And some of them will start developing symptoms around day 6 or day 7. So essentially, you have two groups of people. One is that they are going to be asymptomatic, and the other two is that the other two is the symptomatic cohort. But actually, because you screen the entire building, you actually caught the virus very early on, and they haven't passed they haven't you haven't go through the incubation period to have enough viral load to cause symptoms. So you would definitely see this phenomenon that, okay, we screen the entire building and you caught some people that's really early in their disease, and their symptoms really don't come until later, day 6 or day 7. And because these infections, they happen in clusters and outbreaks, staffing shortage is going to be another obstacle that you're going to be looking at when you're trying to address symptoms. What happens if a lot of your staff are sick and calls out and you only have one nurse and one aide on the nursing floor? Then there's not too much symptom management that they can do. They will be scrambling just even trying to serve enough water and food to the resident. So definitely staffing issue is an obstacle in symptom management and monitoring. You know, Takashi did a very good job of summarizing the medication that you use if your goal is to address symptoms. And COVID-19 is really no different than any other respiratory infections or managing heart failure, morphine to take away dyspnea. Oftentimes you're asking yourself a philosophical question, whether you're really trying to aim to treat and prolong the patient's life or survival, improve their survival, or you're really respecting their wishes just so that that their wishes are comfort and care, and that you need to follow their wishes. Then you're only addressing the symptoms at that time. If you're really just addressing the symptoms, then morphine, lorazepam, Haldol, glycopyrrolate, like Dr. Wermera recommended. But if you're looking if the family is really asking you to go the other way to look at survival and looking at their improving their chance of survival, it is important that you need to discuss with the family that, okay, if you're looking at even comfort-oriented care, it doesn't mean that you're not treating them. You should still discuss using maybe high flow in the hospital if that's available. And you really need to present family with all the options of treatment, even the patient is just comfort-oriented care, so that you cover all the bases. That's all I have, unless somebody else have any questions.
I have a question. So at the point, I'd like to, talk about, like, does the nursing home have the capacity to provide the comfort care, right? So if they're short-staffed, and I know you talked a little bit about using the possibility of IV and sub-Q morphine. Most facilities here are not comfortable doing that. It's just the oral sublingual. If they're not able to provide the IV morphine, or if they're not able to provide adequate symptom management, do people talk about transferring to the hospital to provide the adequate symptom management, although that was something they didn't want to do in the first place? Have you encountered those problems in nursing homes there?
Actually, the sublingual medication, the sublingual administration of morphine worked in 99% of the time. I haven't had a case that I need to transfer to hospital for symptom control. And if a patient is passing from the coronavirus, they usually pass pretty quickly. So a lot of times what we see is that they pass right after 2 drops of morphine were given, and that's it. So they sometimes they might pass before you even had time to titrate it to make sure that they're to the state that they're comfortable.
Yeah, and I think that's why, again, if you have an option to do IV, I think IV might be better. And I think our hospice people should create some system maybe to address this crisis, so that, I don't know. I hope Dr. Wen come up with some idea. I mean, I hope let's say there is a palliative care unit in the hospital so that patient can go there and then manage the acute symptoms.
Mm-hmm.
But there is no such system in Hawaii much, so I think this will be a challenge. As Eric, Dr. Chen said, maybe we may not even have time to transfer these patients, to
Yeah.
other place.
No, I know that nurses aren't comfortable placing the IV and then pushing the morphine, but of course they're very comfortable if hospice comes in and puts in the PCA pump. That's easy.
Yeah.
Well, then that's the question. Would hospice be fast enough to come in, put in that PCA pump, and then leave it to the nurses to press the button?
Wow.
That remains to be seen.
Yeah.
Okay.
Dr. Chan, I think you last time mentioned about about the family saying goodbye, come to nursing home, and then how you handle the situation. Can you share that story again?
Are you talking about the no visitation rule? And actually, it's really up to your nursing facilities administrator and their policy. Some nursing facility follows a very strict guideline. They only allow one visitor and 1 hour a day. Some are more relaxed. They allow 3 hours, 3 hours of visitation and 3 different visitors and one hour per visitor. The most basic rule that I tell my administrators when they come to me for advice is that as long as they can practice the proper social distancing rule, then we should try the best to accommodate the family's needs. Of course, if your rooms are big enough and if your hallways are big enough and you can handle 2 family members at a time to make sure that they maintain the proper social distance, 6 feet between your staffs and other residents, then I really see no valid argument to not to ask them to come in if that's what the family need to say goodbye.
So no hand holding with gloves or PPE on?
When they come into the building, our nursing facilities provide them with a full PPE, surgical mask, eye protection, gown, and gloves.
Wow. When families visit at the end of life, is it better to allow visits 1 hour per day or allow visits on the last day for more extended time?
It's a difficult thing to say. It's really up to families. Some family even tell me that they're scared of coming in because they have other elderlies at home and they don't want to pass it to their loved ones. When I tell a lot of families ask me when's the best time to come in, I always tell them that it's pretty obvious if the patient stops eating and drinking, then their time then their time's closed. And the sooner that you can see them, then the better, because they're only going to decline from this point and on.
Mm-hmm. I have another question I'm kind of wondering about. Is there a role for something like a baby monitor? Because if you cannot go in as frequently, you're so short-staffed, setting up a few baby monitors and then with a little TV thingy at the nurse's station or whatever. I mean, is that something you think might be worth investing in?
I don't see any reasons or regulations why not. At this stage, any communication, even just visual, family would definitely appreciate.
Yeah, but I think also Ida Wen is talking about the symptom monitoring, and I think might be a good idea.
I kind of wonder if hospice can help provide that, in general, if they can come in fast enough, right? So as an additional thing,
In Washington State, as soon as there's an outbreak, in a building, the nurses are obligated to check their temperature and oxygen every 8 hours. So, so when they started to develop symptoms, when they start to have dyspnea, you can usually expect it, because you will see that the oxygen start to drop, and then they start putting them on oxygen. So you can definitely have some time to catch them.
Mm-hmm. Yeah. Yeah. What about the use of technology like Zoom, FaceTime for family presence? Has that been used in your facilities?
Definitely. And sometimes that might be the only way that we can get them to see a specialist.
Mm-hmm.
And can you tell me like how you provide a phone or iPad to patient? Are you using their tablets, or do you have their own? And Dr. Chen?
Sorry, I didn't hear your last portion of your question.
Sorry. Have them use your facility's tablet. In that case, you may need to disinfect the tablet. So I'm wondering how you've been dealing with that.
Yeah, we have one set of tablets that's just used for COVID-19
Okay. Wow.
wing.
All right.
So they can go in between, and we don't really need to worry about sanitization. Of course, if you have a MRSA, if you go between a COVID-19 patient plus MRSA or plus C. diff, you definitely have to sanitize.
Yeah. Okay. All right. And then, of course, room cameras, right? That's baby monitors on steroids. If people have the money or the resources to purchase such things. And I guess there's a question about whether or not the residents are aware to benefit enough from the Zoom or the FaceTime or privacy issues. I would just venture to say that sometimes, we don't know, but maybe just by their hearing, their family member is enough, even if they cannot respond. I wouldn't underestimate that.
Yeah, and I always, as a palliative care patient, I tell to family, even though they cannot respond, they hear you. So please say whatever you need to say, something like that. It is very important.
Yeah. I guess there might be a privacy issue with baby monitor out in the nurse's station, but maybe in the back room or something more private, where people will keep it HIPAA. Okay, so we got 2 minutes left, and I just want to say thank you to everybody, all your sharing. And just to say, in order to get your CMEs, CEs, or certificates of attendance, go to the webpage and complete the online evaluation form. And the link is at the bottom of the email invitation. The link was actually posted at the top of this Zoom chat. And anyway, please also just type in any topics you would like to see in the future. And please tune in this coming Wednesday at 2 p.m. We're going to talk about COVID readiness in the care home, because we should not neglect that these are care homes are very common here in Hawaii, not just nursing homes. And so we're going to have folks from Department of Public Health and MedQuest Division and KCC to talk about how they're helping get all their care homes ready. So if you guys know of any care home operators or colleagues, make sure that they join us this coming Wednesday. Okay, thank you very much, everybody, and so glad to see such a wonderful participation today. Thank you.
And name Sonia Winslet, Winslet, if it didn't come through. Okay,
great. Right. Anybody else on the phone wants to just give us your name? Okay. All right.
I think
Hello?
It's Dr. Sloan Bobby speaking.
Okay.
Thank you very much.
Thank you.
Thank you.
Okay. All right. See you Wednesday.